So there is a chat box that is available. So if you cannot, we want to encourage you to chat in a question during the webinar so we can record them. And we really look forward to sharing this information with you. So managed care and CTAC work together to help a wide range of providers make a successful transition to managed care and have access to the training and technical assistance they need to adopt effective and efficient service and business practices. Family peer support service providers are one group that is definitely a focus of these technical assistance efforts, and we are glad you are able to join us here today. So as you can see, we have a bunch of partners that are all working with CTAC and MCTAC. And we are working collaborative with these partners to offer you guidance rich with different types of expertise. And it is noteworthy, as you can see from the logos, that we have two peer organizations, Families Together in New York State and NIAPRIS, and they are key partners in this collaboration. So again, our presenters for today is yours truly, Geraldine Jerry Burton, and we also have Ann Cuppinger as well as Boris Bjorgren, who we all work together here at CTAC, and we work in partnership together. So for this webinar, part one, our objectives are, number one, to understand how managed care fits into all of the changes taking place, and to begin to understand basic managed care terms and concepts. So as you can see there from our slide, there are many moving parts that are happening, but the focus of this webinar is on managed care. Managed care is one of many interrelated changes that will be happening. This webinar will not go into depth about all of these changes, but will hopefully put our conversation about managed care in context. We have fairly narrow objectives for today. And again, as I said, we'll be focusing mainly on managed care. So the children's plan goals, as you can see here, you have all heard about the children's plan, and the children's plan has these goals, and accomplishing these goals involves not only the transition to Medicaid managed care, but it also involves some of these other changes, such as children's health homes and Medicaid expansion. The transition to a managed care delivery system is a critical part of this plan. Currently, we are in a fee-for-service delivery system for behavioral health services. So one way to keep up with all the changes regarding services for children and families is to listen to live or via recorded webinars, and these proceedings of the Children's MRT. This group has broad representation, meets quarterly, and is led by children's leadership teams from OMH, DOH, OCFS, and OASIS. Just to be careful as you listen to recorded webinars, as the timelines and details are continually changing and being updated. If you want to be added to the Children's MRT listserv, you can email Angela Keller, and she will add you to the group. You will then receive announcements about upcoming MRT activities. And as you can see on the slide, her email contact information is angela.keller@omh.ny.gov. And again, I want to stress, please, dates are consistently changing, so be aware when you are looking on the site.
Hi, everyone. This is Ann Cuppinger from CTAC, and we're on this slide here. We've given you the email or the web link to the information on the Children's Medicaid Redesign Team, and you're going to see throughout this presentation, we've included some screenshots of these pages, and more helpfully, the links to these pages. There really is a wealth of information. Sometimes it's a little hard to find these sites on various government websites, so we're hoping that this helps you navigate there so you can visit periodically for updates. One of the reasons we're doing this presentation today is because it's really easy to sort of, in your head, have a mashup of all of these different changes that are taking place. And, you know, they are related to one another, but we wanted to kind of pull out managed care as a topic and place it in context of all of these changes, and then give you a little bit more information on the managed care and how managed care operates, and to help you start to think through what some of that different way of viewing the world of children's services, the impact that that might have on the way you do business. So this is part one of a two-part webinar series, and we're really hoping that as we go through this webinar, you will chat in any questions that come up as we are talking. We will not be able to answer all of those questions today. Hopefully we can pull out a couple of questions to answer, but we will be able to take a look at those and incorporate responses to many of them in the Part 2 webinar. So in addition to the Children's Medicaid Redesign team, which is, you know, kind of looking at all of these changes, there are some specific other initiatives going on. And one of those that you've all heard about are health homes serving children. So again, with health homes, really, if you can think of health homes as care coordination, you know, that's a step in the right direction, because a lot of people are sort of looking for the address of the health home, and it really isn't a place. It is another form of care coordination. And the idea of a health home is to coordinate care not just around the child's behavioral health care needs, but also around their physical health care and the other kinds of supports and services that you all know families really need to be healthy and successful and to help their kids thrive in school and at home and in the community. So health homes designated to serve children will begin a phased-in enrollment beginning in January of 2016. That was originally going to start in October, but that date's been moved to January of next year. So there is a page on the Department of Health website where you can find up-to-date information on all different kinds of aspects of health homes for children. Another initiative that you've undoubtedly heard about is the Delivery System Reform Incentive Plan, or DSRIP. And the idea of DSRIP is to help shift practice. Basically, hospitals are forming networks that include hospital and other system providers with very specific goals of preventing emergency room visits and hospitalizations. And their payments are contingent upon them being successful meeting these targets. Most of the initiatives that, and they have an array of initiatives that they can choose from that are laid out by the Center for Medicaid Services. And most of those initiatives do have to do with adults. There are some that pertain to children. And we are encouraging, and those networks that are forming are called Performing Provider Systems, or PPSs. We have a number of family support programs around the state that are actively involved in their local DSRIP activities through one or more performing provider systems. And we're really encouraging you to be a part of that process, be at the table, look for opportunities for you to bring your expertise into the mix. It may be in ways that you haven't traditionally operated before. I just heard about a program yesterday that the DSRIP is engaging around an anti-stigma campaign, because that is something that you all are really good at and can do on behalf of, you know, all folks receiving services, adults and children. So we're really interested to hear from any family support providers or children's providers, for that matter, who are involved in their DSRIP initiatives, because it'll be interesting for us to get an understanding of where that activity is taking place. But when you hear that it only pertains to adults, we're really encouraging you to, you know, understand that that is to some extent true, but get involved anyway, because the networks that are forming around DSRIP may be very important as we move into Medicaid managed care. And this is the website that will provide you with additional information on DSRIP, including helping you locate where the participating provider systems are in your area. There are also some changes that are being made to the Children's Medicaid benefit package. So every state has a Medicaid state plan. And if you make changes to that plan, the Center for Medicaid Services has to approve any of those changes. So the Children's Leadership Team, which consists of representatives from the Office of Mental Health, the Department of Health, the Office of Alcohol and Substance Abuse Services, and the Office of Children and Family Services, they are all looking across their systems to see what kind of changes are necessary in the Children's Medicaid benefit package. So one of the things that you'll hear about is a state plan amendment, or a SPA, and the services that are discussed in that state plan amendment are sometimes referred to as SPA services. As a person who lives near Saratoga, I at first thought perhaps this was a lovely retreat sort of oriented spa service. And then, once that was defined, I, thought it was kind of amusing that we weren't actually providing relaxation therapy for families. But in fact, the new state plan amendment services are new services that are being added to the state plan, or services that are being moved from a waiver level of service into a state plan service, with the hope that they will be made more broadly available to kids and families, who meet the medical necessity criteria for receiving these services. So on this slide, you'll see the 6 new state plan services, and I just want to point out that one of those services is Family Peer Support Services. And, I think this is a good thing for family support because it will allow you to do what you do for the broadest group of families, and in a manner that hopefully allows you to stick with a family as their level of care or level of need changes and they enter and exit other parts of the service system. You're all familiar with the Home and Community-Based Services waiver, and there are a number of changes going on in the waiver. We're not going to get into those in great detail, but those of you who work with families in different systems know that depending on whether you're in, for example, the Bridges to Health or B2H waiver, or the OMH, Home and Community-Based Services waiver, depending on which waiver you're in, you may have access to a different package of services. The state's hope is that an array of services can be made available to young people and their families regardless of the system that they're in, to sort of align these services to, allow access to children based on their needs, regardless of what kind of system door they came through. So the timeline for all these changes is on this slide, and please note that this is a dynamic environment that we're living in, and that these changes are, these dates have already changed, and sometimes adjustments may be made in the future. But what we do know right now is that there are some newly proposed Medicaid state plan services that we just discussed, and though an application will be submitted to the Center for Medicaid Services, and when that is approved, and when those programs are, appropriately credentialed by OMH, those services will become available. In 2017, health homes are starting in January, and in 2017, we'll be making, the transition into Medicaid managed care. We know you have a lot of questions, and we just want you to know that as CTAC looks to the next year, 2016, there are a lot of activities planned for children's providers to help you successfully navigate this transition, and that includes, focusing on the needs of Family Peer Support Services providers as well, both those of you who are embedded in larger agencies and those of you who are smaller independent programs. We know that you have a lot of questions about what's going to happen to the existing aid to localities funding. You're trying to figure out, how am I going to continue to provide the service in a way that's meaningful to families, but in a managed care environment? you know, questions around the process for getting services authorized, questions around rates, and then a lot of questions around how your agency can become ready to be a managed care, Medicaid provider agency, questions about billing and contracting and things like that. So we're going to start that conversation today by really focusing on a basic understanding of Medicaid managed care. And with that, I'm going to turn it over to Boris Bilgorin, who is our in-house CTAC managed care expert, and he's going to take it from here.
All right. Good afternoon, everybody. Thank you, Ann and Jerry. So we'll jump in, and as was mentioned, this is part one of part two presentation, but also, you know, a lot of these concepts are a lot of things we're going to be talking today. We're going to be repeating and doing, you know, kind of deeper dives and in-depth discussions as time progresses, because a lot of these concepts and what is managed care and how it works usually requires more than just a one-time presentation or a very brief discussion. So stick with us. If you don't get something we're going through, or if we're going through too fast, please don't hesitate to, as Ann and Jerry said, chat the questions in. But we're also going to be pointing you in different resources and recording this, putting this online, and doing other presentations. So with that being said, let's start with managed care. So one is just taking a step back for a moment and just grounding all of us into kind of where it started. So in 2011, Governor, Cuomo at that time basically, stated, as it says in the slide, it is of compelling public importance that the state conduct a fundamental restructuring of its Medicaid program to achieve measurable improvement in health outcomes, sustainable cost control, and a more efficient administrative structure. And the outcomes he and the state, and actually the country, is moving in this direction, is looking to achieve, is improved health status of individuals, improved quality of care, reduced cost, or at least sustained growth and care management for all. And at that time, through the Medicaid redesign team, it was decided that managed care would be the vehicle this would be achieved. So the slide you have now that talks about the Medicaid expenditure in 2013, and it refers to $49.1 billion. I think the state is now pushing probably closer to $60 billion. But either way, the Medicaid expenditure for New York State is near a third of the total net state budget. And prior to 2013, the Medicaid growth was anywhere from 7 to 10%. It was not sustainable. The cost of Medicaid they were running away, and it kept growing. And the sad part about all of it, not just because it was expensive, New York State was probably the less in quality and quality outcomes, which basically showed that just throwing more money at health care or at a problem doesn't necessarily give you better quality or better health care. And so I think it's important to sometimes step back and say, why did all of this start? What is the thinking about it? And so forth. So the movement from trying to not even maybe reduce costs, but at least sustain the growth. And what the state is trying to do is keep it under 2%, which would be manageable, is important, but not necessarily even the cost, but it really is about improving quality and health care of all individuals who receive, who are on Medicaid. So what is managed care? Managed care is an integrated system that manages health services for their enrolled population, simply for providing or paying for the, it's not just about providing or paying for the services. And the managed care, of course, contracts with providers and organizations to deliver these services. Okay. Why is care managed? Well, it's to improve service quality. So they establish treatment guidelines. They usually, and most time, it's based on research, would focus on outcomes rather than more services. improve the experience of care and satisfaction. One of the things that managed care is really graded on by the state and others is the satisfaction of the as they would refer to them as members, clients, patients that they serve. They have to be accountable for what they're doing. They have to provide care coordination and coordinate care. That it's usually done telephonically. Some managed care companies on a limited basis do it out in the field, but it's predominantly telephonic, but they have to do care coordination. They're very much into wellness and preventive care. Not only is it cost effective, but also it's the right thing and it improves health overall. And of course, they look at it as a population health, not just an individual who's getting it, but as a whole system. How is the whole system and all of their members are doing? And of course, their focus is on value and cost benefit. And again, not just, is there more services. Some of the key concepts for managed care, and we already talked about some of the care coordination. They build provider networks. What that means is every organization, agency that contracts with managed care becomes part of their network. They establish, working with the state, what medical necessity for each service. They do utilization management and review, which for some folks translates to authorization of prior approval process. There's a benefit package. I think Ann talked about benefit packages. What that then leads us to a discussion about providers needing to do, revenue cycle management, which we'll touch base a little bit on. Talk about outcome, value-based, capitation, financial risk, and credentialing. A lot of these are very big terms, might be not familiar to you, confusing. And again, I just want to emphasize, don't worry if, you don't fully understand what capitation is or credentialing, financial risk. One is we have resources on the CTAC. We also have the MICTAC side and other resources where we can point you towards in regards to some of it. But also, we're going to be doing more presentations that are very specific to some of these terms and concepts. So here's a MICTAC online glossary, just to do applause for, which actually defines most, if not all, of the terms I just went through, plus I think a couple of hundred additional terms. And as we learn of new acronyms, and there are always new acronyms, we will be populating and updating our glossary. So I strongly recommend folks visit MICTAC.org. There's a lot of good information out there, and we keep updating it and adding new information, not just to the glossary, but other information as well. So another piece just to be aware of, even though our focus is on the first bullet, which is managed Medicaid, but I think it's important to understand that managed care companies have different products, or what they would refer to products or lines of business. Some managed care companies also have something called Child Health Plus, private or commercial insurance, which is usually, is through an employer who covers their employees. Exchange, Affordable Care Act, or also known as Obamacare. Some of the companies have. There's also, of course, self-pay and sliding scale. Those are not managed care products, but individuals on their own who are not covered by anything might be approaching you. And then there's, of course, managed Medicare. Probably not as common with the children's world, but it is a product that others, the managed care companies have, and I think it's important to just be aware of. But today's presentation, and I think what we're going to be talking about for the next couple of years at least, is really going to be the Medicaid component of it and managed Medicaid. And please continue sending in the questions. As we get the questions, we allotted time at the end to kind of answer them. So please keep them coming, and we'll be addressing the questions later. So how does managed care work? State and managed care agrees to a contract which lays out benefits, limitations, and rules. And so even though you as an agency will be contracting with managed care companies, I think it's important to recognize that managed care contracts with the state, and it kind of starts there. There's rules that are developed between the state and managed care, then some of those or all of those rules have to then kind of trickle down, if you will, to the contracts with you, and then there are some places where managed care has leeway to negotiate with you. And as I said, managed care does contracts with the providers, sets rates, limitations, and rules. We are hopeful that, in some instances, the state sometimes can mandate rates, but unless that is done, then each provider has to negotiate their rates and limitations. And for children and family, referred by managed care as members, just again to emphasize that, and it's also about referring to the, provider state network. So continuing with how does managed care work, providers, in 2017, assuming the timeline stays, providers will work with managed care to determine if the child is eligible and meets medical necessity requirements. Of course, there some discussion about state rules about it and how this will work, but in general terms of how this works, it's really between a provider and managed care. Providers will have to follow utilization management procedures, which at CTAC will be working closely with managed care companies and doing next year. We'll be doing some trainings on this. And of course, the members who use a lot of services are assigned a care manager with the managed care organization. And what that means is then that care manager within the managed care might be calling you and having a discussions about that particular individual, seeing if the level of care or the services the child might be getting are appropriate. Maybe they need more services. I know sometimes folks don't think about managed care offering more services, but they do. And sometimes, of course, talking about, maybe there are too many services or other types of services that need to be offered. So it's not just about reducing services. Sometimes, it can go the other way as well. So again, continuing with the managed care and how does it work. After all is said and done, the provider submits bills to managed care. The managed care reviews the bills to make sure they're accurate and that they fall within the contract and they're authorized. Hopefully, then managed care pays it. There are instances where they deny it as well. But the managed care processes the bills and pays it or denies it. Then there's, of course, quality and compliance audits that managed care can conduct and usually does. And of course, as a provider, you would need to institute something called revenue cycle management, which is really a procedure an organization adopts to manage and track claims through these steps. So it's, and as we get closer to managed care and as you kind of think about it, it really becomes part of the need to build out infrastructure, because every time you bill, you do want to get paid, and you want to make sure that you actually get paid. And so talking about getting paid, so the way to try to assure, there's never a guarantee, but to, kind of increase your chances of getting paid. So what is a provider to do? They want you to make sure that a member, again, as managed care refers to, a member is actually part, an active member of that plan. So the services you provided are included in the service package, that the services were medically necessary, they were authorized, and that you as a provider are part of the network. If you can say yes to all of these things, there's a very good chance you will get paid. If you say no to even one of those things, there's probably even greater chance that you will not get paid. So I think this is just, again, a really cheat sheet here on how to think about it, but clearly, as we all probably know, either through our personal lives or through some experience with managed care already, each one of these could take a life on its own and have its own process. But these are the 5 major things that a provider needs to needs to pay attention to. Okay, so the next thing here is just want to make sure I didn't skip any slides. So let me just go back a moment. Nope. So as we move past managed care, and this is really, kind of just putting this out there, but this is probably a year or 2 or even maybe 3 past the managed care implementation, but very much part of the managed care mission and definitely part of this RIP and everything both Ed and Jerry talked about is something called value-based care. And this is really moving away truly from fee-for-service And two, how do you prove that what you're doing actually makes a difference, that the individual that you're serving is getting better, and that, again, that there's value to the services, and not just, I need to provide more services because I need to get paid. So the state, and you might be hearing a lot about it, is really starting these discussions. Part of DSRIP is in 5 years to transition to value-based. And of course, to really be successful in value-based, you would need to collect data, understand it, and utilize it, because it goes beyond just being able to get paid. It's being able to combine both your services, your outcomes, your payments and costs and so forth, and putting it together into a presentation and a picture that says, I stand out as a provider, and this is why you should be paying for my services, because I serve the individual the best, I provide value services to the individuals, and there's actually outcomes to show that. So again, I think that's really, going forward and thinking maybe a year or two ahead of it. So I'll just want to say, so the next slide, we're talking about what is the value of FBSS. So of course, as what you bring to the table is really, your outreach and engagement, reduce hospitalization and length of stay, reduce emergency room use, increase in HEDIS score. So HEDIS is a national term or measurement system that managed care is measured on, in addition to patient satisfaction or member satisfaction. Two major components of HEDIS, there's a lot of different measures, but two major components of HEDIS is 7-day post-hospitalization follow-up, medication refill rates. This is definitely something that you bring a lot of value to and get able to increase those. Increase adherence to plan, enhance wellness, increase in quality indicators, and promote community support. I think all of these is important for you as you talk to managed care or think about what do I bring to the table, to really consider this, make sure it's part of your rhetoric, and as you talk about it, and there might be a number of other things that you can come up and think of, but these are definitely just some of the things that clearly you bring to the table. And some of the questions for the transition team, right? As you kind of think about it, is your agency going to become a Medicaid provider? I think that's a very important question, one of the first questions you should ask yourself, right? There is a transition to that. There requires a certain way of doing business, and might require additional costs that's associated of becoming a Medicaid provider if you're not a Medicaid provider currently. Have we looked at the results of our managed care readiness assessment? So one plug here, the important plug is, have you done the readiness assessment? So one of the things that we do with the readiness assessment, we give you your individualized scores back. So this way you can see where you stand and also how you compare to your peers in regards to being ready to manage care. And of course, what steps do we need to take to get ready, right? So that hopefully becomes kind of part of your, if you will, treatment plan or service plan in becoming ready for managed care. And what are the values? We talked about some of it, or outcomes. How do we communicate this? Are you talking to managed care? Are you talking to hospitals? Are you talking to others to kind of say, this is what we bring to the table, right? And how can, we help other network providers achieve their outcomes? So what you can do, I think what you also bring to the table is not just about talking to managed care, but also talking to some of the other providers, of course, and who are some of our new potential partners that you can, establish. So, next steps.
Thank you, Boris. Very valuable information, very much so. All right, so next steps. Some of the next steps that I think that we definitely need to be thinking about is creating a team to focus on your transition to managed care. And if your family peer support program is a part of a larger agency, you should collaborate with your agency's team. Then you need to, as Boris was saying, complete the managed care readiness assessment and participate actively in the MCTAC and CTAC activities. Be proactive, network with your colleagues, ask plenty of questions, focus on quality, understand assets, improve and monitor your organization's services, outcomes, family experience, business practices, and financial performance, and review your data. Data is going to be extremely important. And just to piggyback on what the previous slide when Boris was talking about the questions that you could ask your team, don't be afraid to ask questions, because if you don't ask questions, you won't know. And it's much better to know up front what's going on as opposed to, for lack of a better word, whining about this. This is going to happen, so you need to get with the program, okay? All right, so let's see what we got coming up. Okay, so now we'll entertain some questions. Let's see.
So I'm going to take a look at some of the questions that have come into the chat box, some of them to the group and some of them to, to us as presenters. So I see a couple questions in here about what is the specific role for the quality assurance, quality improvement? This is coming from an organization that's a CMA. And I'm wondering, we don't have a live conversation here, but I think Boris might be able to address some of the general approach to quality assurance and how that relates to managed care.
Right. So one is, as you become a Medicaid or managed care provider, one is the documentation, and one becomes an extremely important part, right? Because you're billing for the services you provided. The generic way it works is, if it's not documented, it did not occur. And of course, all Medicaid and managed care services have certain requirements, both on the technical billing side and have on the clinical side. They also have to be very much connected to the service plan, the plan of care, to the goals that were established, and so forth. So what the quality, assurance or quality improvement department at a minimum brings is the ability to, one, audit this internally, to see the quality of the documentation, quality of the services that are being provided, making sure that things are meeting the billing requirements and compliance requirements. That's at a minimum level. When you really start moving towards quality improvement, part of it, the discussion should take you into, discussions such as, is there a better level of care? Is this still the right service the individual getting? Are there other things we should be doing for this individual, or have we missed certain things and be able to recommend this? So these are just some of the things that both quality assurance and quality improvement should be doing, at the same time providing training to the staff who are providing the service to be better at this.
Great. And I think you'll see already for, the audience, the primary audience for this webinar are family peer support services providers, and we're really happy that lots of other people are on the webinar. And we're going to be doing some webinars coming up on exactly what family peer support services entail. There is now a consensus statewide definition for the kinds of activities that would take place as a part of this service. That is a part of the state plan amendment that's going in, so that there is, a more consistent kind of program and service model for this service across the state. We also have in New York State a training and credentialing process for family peer advocates. So, and we will be doing some webinars this fall to introduce to the broader service provider community the way and methodology of the approach for family peer services, which is a peer-delivered service. And by peer, we mean a family member of a child or young adult who has been receiving services in one or more service systems. It could be a child receiving mental health services, a child with special education needs, a child with substance use services, a family that experienced involvement with the child protective system or child welfare, a child with developmental disability, or a child with special medical needs. So these are family members who are specially trained and credentialed to work with other family members to help them navigate the service system, learn what they need to learn to be good advocates for their own children, and help them engage with services in an efficient and effective way. So we have probably somewhere between 250 and 400 family advocates already working in New York State. About 200 of them are already credentialed, and that will be a requirement as we move into managed care that those advocates receive that training and are officially credentialed. Families Together in New York State is the agency that's doing that credentialing. And we're really excited at CTAC. We're going to be rolling out some new training that's directed at a number of different audiences. So I'm going to, so that was sort of a long answer to the second half of the quality assurance question.
I wanted to know what's going to happen to the children's day treatment program.
Okay, so we have another question asking what's going to happen to children's day treatment programs. And I think that really at this point there are a number of people meeting to discuss what's going to happen with children's day treatment programs, and we don't have the answer to that yet. I think that will be forthcoming. You'll start to hear some more conversations about that early next year. Another question here that's coming up is, what are our thoughts about the possible merger of Oasis and OMH in New York, and how will that impact managed care? Who wants to take that? You want to take that, or I'll pause it?
I think that's something we would have to think through and probably come back. One,
Right.
As the question implies, it's possible, but and so we would have to figure that out.
There are a number of hearings going on around the state where folks are having an opportunity to have input on that question. I know some of them have already taken place, and I'm not sure if there are any still remaining, but I'm fairly certain that there is probably a website where you can also submit both questions and comments about that process.
Right. But I think in regards to how it affects managed care, again, I think we would need to wait and see. But Oasis and OMH are working extremely closely with the whole, at least on the adult side, implementation of managed care, which for New York City is going live in like a couple of months for adults. And they're very much, kind of hand in hand, working together, developing the rules, the regulations. So I'm not sure if there's going to be much of an impact or change. But again, I think we'll kind of track this as everybody else tracks it and see how that develops.
Okay, thanks, Laura. Another question that we're getting has to do with demonstrating value and what programs can be doing now in terms of data collection to begin to understand the services that they provide and understand the costs associated with those services. So I think probably, I can take that question and Boris and Jerry can add in. A lot of family care support services programs collect basic demographic data, and that's great. That's a great start, sort of understanding, the population of children and families that you provide services for. Some programs also collect information on exactly what they do with families, so how many visits, what kind of work, and that's a really great idea as well. If you're not already doing that, it's something that you can begin to think about gathering some information that helps you understand your level of involvement with a particular family, but also kind of what's a typical course of service look like. Or maybe it looks like you have 3 groups of families. One group that really just calls you for information and referral, another group of families that have a little bit of involvement, but they don't stick with you long term because they're either okay and they don't need your services anymore, or they kind of come and go from your help. And you might have families that you're very seriously involved with intensively over a period of time. So anything you can collect in a coordinated and consistent way to help you understand the families that you serve and the way in which you serve them is really excellent. And then, the next step after that is to understand the cost of providing those services. And if you know your total budget and you have a sense of, how many families you serve and the number of hours of service that you're providing, figuring out your costs, at least in a rough way, is not complicated math. But you'd want to factor in things like mileage and all of the, benefits costs associated with your staff. Any of the costs that you incur in the course of providing this service would go into that equation. And that's something that you can begin to take a look at now. And finally, I would say that you should be looking at the outcomes of your service. So what kind of a difference do you make for families? And I know for many years in this work that all of you are able to share lots of anecdotal information about the impact that you have on families, and that's very powerful and it's very important information. But you also want to be doing anything that you can to measure outcomes in a structured way. So there may be some simple tools that you can use. Most family peer support services providers have been trained in the use of the FANS, or Family Assessment of Needs and Strengths tool. And that allows you to ask, a few questions. I think it's about 15 questions. And you can ask those questions, in a conversation with the family at the beginning of their involvement with you, and then periodically throughout the time that you're working with them. And it will help you understand the family's needs, but also track with the family whether you're making progress, whether changes need to be made, and what kind of impact you're having. Other people use things like the family empowerment scales or other instruments to try to measure the impact that they're having on families. And then the other thing would be to try to gauge your ability to help other providers meet their objectives. So an example of that might be if you've paired a family advocate with a clinic program, and that family advocate's job was to really help engage the families, you might measure a reduction in no-shows, or you might measure the extent to which the family participated in different kinds of activities at the clinic rather than just the original reason that they were referred. Or you might look at, a family's confidence in implementing the treatment plan or the discharge plan. It will look different depending on who you partner with. But that is, and I think Boris mentioned this earlier, what you do is important in terms of your impact on families, but it's also important to look at your ability to help other providers meet their objectives, because that's one of the things that we know that family support services does well.
No, you covered it nicely.
Absolutely,
so,
definitely.
Okay.
So someone wanted to know, do we anticipate OPWDD eventually entering into the managed care model, and if so, when?
I think we don't know that answer. Right. I know there's always a lot of talk about OPWDD.
Right.
But yes. Okay.
So someone asked a question about, just a clarifying question about FANS. FANS is the Family Assessment of Needs and Strengths. It is actually a subset of questions from the CANS tool, which is the Child and Adolescent Needs and Strengths tool, which I think most of you are familiar with. And if you have more questions about the FANS tool, you can email me, and my email address will be on the slides that you'll receive within a week or so of this webinar, and I can put a copy of the FANS tool in your hands. FANS trainings are going on around the state right now for waiver providers, family advocates and intensive care coordinators in waiver, and also for some other providers, and we can get you connected to some of those activities.
Good.
We're getting a message that you have no sound.
Oh, it says, in terms of the value-based criteria, where do we go for that information?
If someone could chat into the chat box whether you can hear us right now, that would be great.
Assuming they can hear us.
Assuming you can hear us. You're fine. Okay. I'm sorry to whoever it is that can't hear us, but I'm glad that it's not a universal problem. Some of you may have heard at the beginning of this webinar we were having a number of technical difficulties, so I apologize for the background noise there, and sorry for any difficulties that you're having. But Jerry, you had another question?
The one about, what was it?
Value-based criteria.
Oh, yeah. I'm sorry. In terms of the value-based criteria, where do we go for that information?
So all of that is still being developed by the state. They're now putting together, at a state level, some of the value-based committees and focus. But I think what Ann went through is kind of information and data you should be collecting and looking at. I think it would be important no matter what the state develops. I mean, again, basic information about who do you provide service to, how long, how many, how much does it cost. Again, everything that was said, I think you can't go wrong with having that information.
Okay, thanks, Laura. So the next question, how will families learn about how to navigate this very complex system?
Well, we're looking at each other to decide who to answer the question. I'm sorry. I think that it's interesting that this question that you asked is really starting to rise to the surface. Up until now, a lot of this discussion has taken place kind of behind the scenes. But as families are starting to hear about, especially changes in the waiver and the implementation of health homes, and the possibility with the conflict-free case management requirements on waiver that they might have to change providers, it's starting to, really, come through in the form of questions from families. We just had a conversation this morning here at CTAC about, what role we may play in terms of putting together information that's specifically designed for families. And, while, this hasn't actually been sort of scoped out yet, I'm absolutely certain that based on the way CTAC works in general, that will be done in partnership with all kinds of consumer and advocacy organizations so that we get that word out, as best we can. And I would hope that that would include sort of two-way conversations, information about how the system is supposed to work and information back about what families are actually experiencing so that, those whatever barriers and problems are occurring can be addressed.
Okay, thanks, Ann. I don't see any other questions.
I'm going to throw a question out that I got 3 emails about this morning, which has to do with for the independent, smaller family support programs that don't have a history of billing Medicaid. How should they go about deciding whether or not they have the capacity to be able to take on the infrastructure demands associated with being a Medicaid service provider. This is a conversation that has been happening with the adult providers, the smaller adult providers, who many of whom are peer services providers, but not all of them. McTAC has done a series of workshops around first understanding what those infrastructure needs are, and those workshops are on the McTAC website, and I think absolutely appropriate for children's providers, small children's providers to view because the infrastructure issues are the same. You'll see some adult language and references in those slides, but I think that the basic structures are going to be the same. And I think as we move through this fall and into next year, there will be some opportunities for small providers to, children's providers, to have some of those same conversations and get the information that they need to bring back to their boards and their community partners to make some decisions about whether they have the capacity to do this on their own, whether they might want to partner with other small provider agencies to create a collective back office, whether they might want to contract for some of those infrastructure supports, or whether they need to make a strategic decision to become a program of another agency or merge with other small providers to become, in effect, a larger unified provider. So, this is one of those things where each organization is going to have to take the information that CTAC makes available and make a set of decisions that, that their board and their, members are comfortable with. Okay, we have one more question. Hang on a second. Have the MCOs been chosen for each region?
Well, so each region does have managed Medicaid designated, already. So, for example, in New York City, there are 10. Each region has their own designated managed Medicaid companies. Actually, MCTAC, another tool that we just developed and put out there, is called the Matrix. It's on our website. It's the map of the state. Right now, New York City is the only live component, but if you click on it, it gives you the 10 managed care companies, managed Medicaid companies in New York City. We will be populating this with all other areas. However, when it gets closer to the children's transition in 2017, I'm pretty sure the state will go through a designation process for that line of business or that product. But at least on a general level, there are already designated generically managed Medicaid companies.
Okay. I want to thank everyone for their participation. The questions that you asked in the webinar today were great. We are going to be doing a part 2 of this webinar, and I want to encourage people to take a look at this slide. These are some of the topics that we hope to cover in part 2. We're going to look a little bit more at this idea of demonstrating your value and taking a look at how you might look at your outcomes. We want to look at in a little bit more detail at some of the changes your agency might need to make to adapt to managed care and help you understand at least the framework of the infrastructure that would need to be in place if you're going to be a Medicaid service provider. And, you know, we really want to respond to as many of your questions as possible and structure that webinar around some of the things that you're interested in learning about in terms of Medicaid managed care. So if you haven't had a chance to chat those questions in today, we encourage you to email us and let us know what those are, and we'll be letting you know what that date is for part 2 of this webinar. In the meantime, I really want to encourage you to visit both MCTAC and CTAC websites. If you spend some time there, you'll see that there's all kinds of archived webinars. There are archived videos of some of the live trainings and information sessions that have occurred, and a lot of different resources. If you sign up for the listserv, you'll hear about things as they're announced. So thank you so much for your participation today, and we look forward to seeing you in future CTAC and MCTAC webinars.
Thank you.
Thank you. Have a great afternoon.